of antibiotics is the cephalosporins. Like penicillin, cephalosporins are bactericidal. They interfere with cell wall synthesis of the bacteria. When administered, they are widely distributed into most body fluids and tissues. Cephalosporins are classified in 4 generations based on their activity. In general, as they move from the first to the 4th generation, they become more active against gram-negative bacteria and less active against gram-positive bacteria. Indications for cephalosporins include infections of the respiratory and urinary tract, skin and bone infections, septicemia, gonorrhea, and bacterial meningitis. They are also used prophylactically. If a patient has a severe allergy to penicillins, then cephalosporin should be avoided when other options are available. This is because the chemical structure of the 2 drug groups is similar. There is up to a 5% risk of cross-sensitivity. However, it is increasingly believed that the risk is relatively low and that each patient should be individually evaluated should the use of a cephalosporin be indicated in a patient with a history of penicillin allergy. Examples of first-generation cephalosporins include cefazolin, Ancef, and cefridine. Cephalosporin is often administered IV immediately prior to the first incision in the OR and continued post-surgically for 1 or 2 doses prophylactically. First-generation cephalosporins have limited effect on gram-negative bacteria, but good effectiveness on gram-positive bacteria. The patient is a 74-year-old male. During a routine doctor's visit, he was found to have occult blood in his stool. He was scheduled for a barium enema and a colonoscopy. These tests reveal that the patient had a cecal tumor. He was scheduled for a surgical excision of the tumor. Because the nature of this patient's surgery placed him at risk of infection, and the area of surgery has a greater predominance of gram-negative bacteria, 1 gram of cefotatin, cefotin, was ordered pre-op and continued post-operatively every 12 hours for 24 hours. This patient is a 70-year-old female who presented to the ER complaining of cough and fever for 3 days. She had chills, shortness of breath, and her cough produced yellow sputum. On assessment, her lung sounds had crackles at both bases. Her temperature was 100 degrees oral. She denied any significant medical illnesses. She took Tylenol for fever prior to arrival. The patient has a history of smoking a pack a day for 20 years. She reported allergy to penicillin. On interview, it is determined the allergic reaction was a mild, non-urticaric rash occurring over 20 years ago. The physician decides this presented a minimal risk of allergy to cephalosporins. A sputum culture, CBC, and chest X-ray were ordered. She was to be admitted to the medical floor for IV antibiotic therapy and respiratory support. The patient was started on Rocephin and azithromycin, Zithromax, as empiric therapy for community-acquired pneumonia while cultures were pending. Current outpatient therapy for community-acquired pneumonia is azithromycin alone. Supplemental oxygen and respiratory treatments were ordered to enhance mobilization of secretions. The X-ray